So good morning everyone. Today we have almost 3.5 topics have to cover. So it's almost like every topic is in itself is in big class. So I'll give you brief introductions and what typical like for you, what you have to, you can write in exams, and if somebody asks you, what you can able to elicit some things. So it's not all about allergic rhinitis, atopic dermatitis and urticaria, including angioedema, but it gives you in broad line what is allergic rhinitis, atopic dermatitis, urticaria and all these things. So it's not, we are not covering throughout all the topics, but for your purpose and at MBBS level it is fine, we'll cover up these things. So today we are covering allergic rhinitis, atopic dermatitis, urticarias, including angioedema. First one is, what is allergic rhinitis? And if somebody is not interested, don't talk. I'll give attendance, but if I'll note something, I'll not give you marks, despite you present in class. So please, if you are not interested, don't talk. Do whatever you want to do. That is not my business. But don't disturb the other ones. Okay. So what is allergic rhinitis? So allergic rhinitis is like as per area guideline. This is what is area guidelines is allergic rhinitis and is impact on asthma. It's defined by all these three criteria. If it concludes all of these, then we can consider them into an allergic rhinitis. First, what is first? Type 1 hypersensitivity inflammation. What does it mean by? Means by immediate hypersensitivity inflammations of the nickel. Kar do ek baar aloud kar do. So basically, what's the definition of allergic rhinitis? It's like it's type 1 hypersensitive inflammation. What do you mean by type 1? This is immediate hypersensitive inflammations that is mediated by IgE. So first thing is type 1 hypersensitive inflammations. And how do, what's the symptoms? How does it occur? Because of allergen substance. It can be anything because of dust, house dust mite, cockroach, pollutions and all things. We'll cover on later slides. And what's the different, how we'll define what's different type of symptoms. So basically we have four cardinal symptoms. First one is sneezing, then rhinorrhea means watery nose, running nose, itching, nasal itching and nasal block. So out of these are the four cardinal symptoms. So at least we should classify them on the basis of these symptoms, and then should be present for more than 1 hour a day for at least many days in a year. We'll classify the severity on the basis of. So basically, the definition of allergic rhinitis should cover all these three criteria. And the first one is what's this? It's so common. Even some of us are also affected with these things. It's not an disease of pediatrics only. It's related to adults only. Sinusitis, rhinitis, atopic dermatitis. So it's all in parameters of these allergic atopies what we have. So it's basically common. 80% of asthmatics have allergic rhinitis, and around 50% of allergic rhinitis later developed into asthma or can have comorbidities like asthma. So it's a very common identity. Usually we find these with 40% of children have at least faced these allergic rhinitis in their lifetime. So what we have discussed in previous slides was four symptoms: sneezing, rhinorrhea, nasal itching, blockage. So on the basis of we can classify them intermittent and persistent. Intermittent means sometimes it gets elevated, then it's an relapsing course. We don't feel any. Again, after 2-3 months, it's flare up again and again. Persistent means it's throughout the months or throughout the year, throughout the day. So when we classify them as intermittent means less than 4 days a week, means after in a 7 days we can have at least less than 4 days, or 4 weeks means in a month, less than a month. So we can, that's the symptoms is present less than 4 days a week or less than 4 weeks. So we can classify them in intermittent. Persistence means more than 4 days a week or more than 4 weeks. Mild and moderate symptoms are both same if the symptoms not affecting normal sleep, no trouble in daily life, sports, leisure activities, no activity, no problem in school, absenteeism and all these things, and no troublesome symptoms, no awakening in night sneeze because of sneezing, blockage, itching. So we can consider and we can classify them in mild category. But if these symptoms convert into severe categories, like they have difficulty, because of blockage, because of itching, they are unable to sleep, there is a sleep disorder, cycle disturbed in daily life, exposure and activities because they are unable, because of these symptoms persist throughout the day, they are unable to concentrate in schools and all these things, schools and workplaces, and troublesome symptoms, they are bothering, so much of symptoms are bothered, that they are unable to perform their routine activity, like you're sitting and you are suffering from all nasal itching, blockage, and on and off, on and off. So not able to concentrate on whatever you want to do and all these things. So on the basis of severity, we can have intermittent symptoms, we can have persistent symptoms, and mild and moderate symptoms. So we can crisscross these things. We can have mild persistent symptoms, mild intermittent symptoms, and moderate. And because why this is important? First thing is the classification. It's important because how we will manage, what type of treatment we will decide. It's depend on these classifications. So we have mild symptoms. We'll go with different antibiotic modalities of treatment. If we have severe symptoms, we go with different. So that is why it's important, because and once we start with suppose anybody is with persistent moderate to severe category with persistent symptoms, so we'll start with therapies we'll discuss in later slides. But when we do up in follow-up, we'll find the symptoms subsides only, then we'll step down the treatment part. So that is why it is important. Plus we classify, then we'll choose which category the patient lies on, and then we'll start the treatment part. So that's why this classification is important, and this is main thing. So this is clinical classification. What's the triggers? All of us knows that there are different type of triggers that can in any patient with atopy, either it's atopic dermatitis, allergic rhinitis, asthmatics, can have these all symptoms. So these are the triggers: allergens, pollutants, and drugs. So allergens, we can have indoor allergens, we can have outdoor allergens. Allergens, indoor allergens like house dust mite, danders of pet animals, cat, dogs, and all these things. Dust animal, insect animal, house dust mite, cockroach, pet danders. Latex, like we are from medical people, we do use gloves that contain latex. So we can have latex gloves and allergy for these things. Pollutants, we can have indoor and outdoors. Indoor, like some of us in villages still use this biogas mass and all these things. We don't have gas, and this, so we have biomass fuels, tobacco, gas, pollutants. Outdoor we have, like we're traveling, we have pollutions of so much of smokes and this gas what cars are existing. It is ozones, oxide of nitrate, sulfurs, and diesel exhaust. Some drugs do cause inflammations and they flare up allergic rhinitis, like aspirin, and NSAIDs like ibuprofen, Meptal, and all these things. So these are the different triggers of allergic rhinitis. It's not like, because if allergic rhinitis persists not taken care of, they can convert into the weekend association of different comorbidities. Means other conditions we can able to find out if we ask in history and taken clinical examinations. We can able to elicit, because allergic rhinitis itself can live and can be mostly, like I've discussed, like 80% of asthmatics can have allergic rhinitis, and almost 50% of allergic rhinitis in pediatrics can convert into asthmatics. So it's not like the person on the first time comes to you with allergic rhinitis. If you ask, if later on life it comes with severe persistent symptoms, we can ask different questions, and then we're able to find out they can have primary and secondary comorbid conditions along with them. So what's the primary comorbid conditions? We can have allergic rhinitis with asthmatics. We can have sinusitis associated, and otitis media with diffusion, conjunctivitis, laryngitis, atopic dermatitis, recurrent upper respiratory infections, LRTIs, and obstructive sleep apnea. These are the primary comorbid conditions that do lie with allergic rhinitis. So if we able to we taken history, we should also conclude these things. We are able to elicit. We should find out what's different features or different symptoms of allergic rhinitis patients can have. So we can have these associated comorbid conditions along with allergic rhinitis. And secondary is, because of allergic rhinitis, we can have different comorbid conditions because of these persistent symptoms of allergic rhinitis. What can we have? Because what we have discussed in previous slides, plus we have moderate to severe, like sleep disturbances, daily sports activities, and all these things. No troublesome symptoms, sleep disorders. So in later, what we will able, like decrease quality of life, not able to concentrate in schools and all these things, not able to perform daily activities, and so snoring because of this blockage in neck. We have bruxism, dental malocclusions because of fingerings, and then adenoid hypertrophy, learning and attention impairment because we're not able to concentrate with these things. So secondary comorbid conditions can be have, primary we do have with allergic rhinitis. Diagnosis. Usually it's in clinical diagnosis what we have seen on, because we have classified allergic rhinitis on the basis of what? Symptoms, and on the basis of durations. So on the basis of duration, we have like 4 days, more than 4 days a week, more than 4 weeks, we have severe symptoms like persistence. So on the basis of duration, on the basis of clinical symptoms, we classify allergic rhinitis. So like investigation is very less role. We classify allergic rhinitis and clinical diagnosis. What we find out, we will able to elicit. We find with the patient comes to you, will able to find out what symptoms do he or she is having. Like first one is nasal blockage, itching, rhinorrhea, and sneezing. So all these are symptoms we can able to find. We can ask the patient on the basis of durations for the most four rule of four: more than 4 days a week, more than 4 weeks, more than 4 week a year, or less than 4 days a week, less than 4 week a year. The rule of four and the symptoms. So we can classify. So that's why it's clinical diagnosis. Mostly it's clinical diagnosis. We go with the investigations, but they are supportive only. The first we will on the basis of clinical diagnosis and durations we classify the allergic rhinitis. So basically it's in clinical diagnosis. So associated we will be able to confirm, it's not confirmatory but supportive, like serum IgE specific. And we have in previous slides what we have covered through with allergens and those things also. We can go with allergic specific IgE test. These are serum tests or skin prick tests. So on the basis of, like, if you have cat, if we ask the history of a patient, particular patients, do they have pets in their house? So somebody says they do have dogs, they do have cats. So after, on the basis of history, on the basis of signs and symptoms, we'll go for specific IgE test. It's not total IgE. Total IgE is a vague diagnosis, and serum like eosinophilic counts. They just tell the patients about they tell the condition of the patients, that patient has a history of atopy. Atopy means allergy. Allergy can be because of anything. It's not like allergy just because of so it can be because of anything. On the basis of symptoms what we have classified, then we go to the diagnosis of allergic rhinitis. So total serum IgE level, eosinophilic counts is a vague diagnosis, should not done routinely. We ask the patients on the basis of history. Suppose he or she resides in the rural areas, and at the time of pollen grains and due to ripening of these different types of, like, they stay in kacha house and all these things, and they use biomass like cow dung, and then we ask the history. On the basis of his symptoms and all these things, we'll go with the test what patient is telling you. So on the basis of particular symptoms, on the basis of denders, pollens, we go with a specific, like a person tells you on the, like, he's not tolerating curd, fluid, and this milk. Some of us can be lactose intolerance and everything. Then we go for a particular type of serum specific IgE test. It's not like vague test. We have to go for overall. This, if we can do with serum, total serum IgE level and eosinophilic count, but they are just tell you the patient is allergic to something. It's not like particular point out. So it's a vague diagnosis, but they tell you that spoiler is sensitive, eosinophilic count are raised, total IgE, serum IgE level raised. But they are not specific. Specificity, we have to find out the patient, take the clinical history, then we go for the particular type of specific tests. Then we will be able to perform these things. So in the second, tick mark, either particular type of disease, allergic specific testing, what we have done, it can be done either the blood samples in vitro IgE testings or skin prick tests. We have touch tests, we have skin prick tests. We'll take in droplet of particular type of allergens and then tick and then mark over these things. And if you find the symptoms, there's really clear, it's a show the responsibility. So we can take as a positive test, particular sensitive too. So we can have these things. Last one I have already discussed, total eosinophilic count, total IgE count, like specificity and sensitivity are not frequently recommended. Management part is overall, it's not always start with the treatment part, but first, because what we have triggers first. So allergens, what we have, if we are able to, we have to take care of all the, we have to educate the patient, we have to take care of like self-monitoring, we have to avoid the allergens, and then we go with the treatment part. So first important part, because it is important, because if you are not avoiding allergens again and again, they are triggers. You can take Montelukast, you can take cetirizine, whatever you want to take. But if you are not avoiding, particularly you are living in a particular environment that is triggering you again and again with a particular type of allergens, you have to take medicines, and symptomatically you will cover up. But if you not avoid allergens, you will not get treated again and again. You will not thoroughly get completed, totally cured. So avoidance, allergen avoidance is the most important part. If in case of allergies, whatever allergy you have, you can have allergy with your creams, you can have allergy with your perfumes, you can have allergy with your incest, these candlesticks and all those things. So we can, if we know we have allergy to a particular food thing, particular insect, particular things, we can with particular drugs we have to avoid, then it's important. So allergen avoidance is the mainstay treatment of allergic rhinitis. And with, depending on what person is particularly allergens to, we have to avoid that particular allergens. So this first thing is allergen avoidance. Avoid areas with high pollinations, fungal and dusty environment. If you have any cats, if you have a pet animal with you, we have to take pest control measures and all these things. Control of house dust mites. Should avoid carpetings and this kalins and all these things. We should avoid because they imbibe dust and all these things. When you just bath them, they will get again and again. We have a dusty environment and all these things. Washing of bed sheet in hot and sun drying, putting mattresses in sun, dust mite encasing materials, and relative humidity, because we do use ACs. They circulate cold air, but that is dry. That's why if some of you are suffering from allergic rhinitis, moist environment, relative humidity is very important and should be kept below 50% to keep your environment should be humid, not it's dry, to prevent you from allergic rhinitis, asthmatics and all these things. Pharmacological treatment is always antihistamines are the first line of treatment. Inhaled corticosteroids. Inhaled means through the nose, not it's systemic. Systemic it is what we are taking through oral or injections parenteral route. But inhaled means directly we are going to the whatever symptoms, nasal mucosa inflammations and all these things. We are directly giving steroids. So antihistamines are first rule of treatment. In case of mild versions, we'll go with the particular these are the slides. But second generation antihistaminics has a superior role because these are less sedatives. Less sedatives means you can go to school, you can go to attend your classes. You can take your levocetirizine in the morning, Montelukast and all these things. First generation antihistaminics have good potency, but what they're very sedative, so you will feel drowsy all throughout your day and should be. But it's good in case of pediatrics, infant and neonate can given first generation antihistaminics. Why? Because they don't have to attend school, they don't have to pay attention to a particular work or in school or in class. They can, because they will drowsy, they will sleep, and when they take a good sleep, they'll recover fast. So in case of small kids, not going to schools, and infant 2 years up to 5 years, pre-toddler, pre-school, we can give first generation antihistaminic. That is good of choice. But in case of adults and teen adults, we should go for second generation antihistaminics. Inhaled antihistaminics recommended for more than 6 years. Oral decongestants, what we have like. You are feeling like choking, and we can give oral decongestant, but we have very typical limited role because they have side effects also. They can give you tremors, insomnia, tachycardias and hypertensions. So we should avoid these things. Main gold standard treatment is INS. Second last one, inhaled nasal corticosteroids. We'll go in the next slides. If you are not responding with inhaled corticosteroid, we can go with systemic steroids also, but for a brief period of durations to control the symptoms. So we can and different type of these inhaled corticosteroids. We have pumps and we have sprays for different. We'll go through these particular slides. These what I have told you. These are particular age group. We can use antihistaminics not below. We should not use less than 6 months. We should not use antihistaminics. It's always because like in whatever you have kid and somebody asks your parents, your doctor tell me we haven't kid in less than 6 months, 4 months. So you just broadly give him cetirizine, syrup cetirizine. You should not be given because it has side effect long term. They have attention deficit on different schools. Should whatever the antihistaminics, whatever you have with starting age is more than 6 months. So these are second generation antihistaminics. You can give cetirizine, levocetirizines, and all this. We can different age groups and different years what we can start, and those we should be given in MG. So these are recommended these. And if you are in confusion, cetirizine is also second generation histaminics, not levocetirizine only. Cetirizine is also second generation histaminics, and it is important because it's just what you are saying is levocetirizine. What you have is 2.5. Same dose is there, and this according to because nowadays we have Avast, Bellastin, Avastin, these, and last one is Avastin. These are so different because they are less sedatives and different less side effects. Techniques of inhaled steroids should be given, and if they are not responding to, we can go with antihistaminics. We can go if in case of resistance, case of whatever you have treated, antihistaminics, inhaled corticosteroids, systemic toxicity, then we have no other choice left with. We can go with biologics, that's immunoglobulins, and desensitization. If you particularly find out a particular allergen is causing this allergy again and again, we have different sublingual immunotherapies and subcutaneous skit and slit. But these are beyond your scopes of to discuss. We'll discuss some other days in clinical classes. And it's not like all drugs we can use, we go thoroughly. It's important with this particular type of symptoms, we can smartly use different type of drugs what we have available. If you have symptoms of nasal and sneezing, it's not always all four symptoms are present with you. Some of them you have, most of them you have nasal blockage, some of them you can have sneezing is a predominant symptoms. In some period you have rhinorrhea of arteries. It's not like, it's very unlikely that all four of symptoms can present. So whatever symptoms the patient is presenting with you, we can use smartly choose particular type of drug. So suppose the patient is having itching and sneezing particularly, so what this good therapies to we can start with oral antihistamines, 3+ topical steroids and oral corticosteroids. Usually oral corticosteroids we avoid. So we can, if the particular, it's not like we broadly classify and just given whatever type of medicines what is. So if suppose if patient is suffering from take nasal obstructions, so topical decongestants means particular in the nasal is more suitable for a particular type of patients, and then oral corticosteroids. So for example, it's so if a patient suffering from nasal obstructions, if you are giving oral antihistamines, see it's a plus minus. So nasal obstruction is not relieved by what? If you are giving oral antihistamines. If you are giving oral decongestants, that is relief for a particular patient. It's not so. On the basis of particular symptoms, you decide what type of medicines, what type of drug you want to give. That will give symptomatic relief to particular patients. Okay. This is broad. This is we have discussed in previous slide. This is broad. If an approach, what if anything comes with an example, this is important slide for you. First one is clinical diagnosis and durations, and last one is this one is. If somebody asks what is approach, suppose a patient comes to with approach, first thing is important is he have to diagnosis, classify on the basis of duration symptoms. So symptoms sometimes rule of 4, sneezing, rhinorrhea, nasal decongestions, itching, and symptoms 2 or more than 1 hour a day of a particular day on the basis of severity, intermittent, and persistence. Supporting evidence based, because we have discussed what is in clinical diagnosis, we don't need any investigations. But if you want, if the patient is very inquisitive, parents are very hard to understand, we want to go for any investigations. So what different type on the basis of particular symptoms, allergens you can go. Nasal eosinophilic count is significantly more than 5 HPF, hyperophilic, increasing IgE 4 times the normal. This is vague, but it's supportive the patient is suffering from allergy. Atopy means allergy, not particular atopic dermatitis or allergic rhinitis. That means the patient is having allergy, but of what kind we will able to elicit. Specific ID testing and skin testing is the gold standard if you want to go with a particular type of investigation. So last 2 investigations. So first we are able to classify, and then on the basis of 14 investigations, the parent tattoo resistance, they want to go in investigations. First classify, and then on the basis of treatment, what we have discussed, first we have to educate the patients, avoid the triggers, don't go in a dusty environment, use mask whenever you feel, if you are, somebody is having allergy to particular type of smoke, since somebody is smoking, don't go to particular environment. So education the patient, health hygiene, on dust matricing, well ventilated areas, sunlight is important. So important is, first thing is important what causing, triggering the symptoms of anything, allergic rhinitis, atopic and urticaria. So avoidance of the particular, so education to patient and particular is important. Then second, what we have discussed, avoidance of triggers, outdoor triggers, oral allergens, indoor allergens, dust mites, biomedical cues, whatever the symptoms, what's the allergen that is particularly triggering the symptoms. Last one is pharmacotherapy. We have discussed in previous slide different type of modalities what we have. So what I have discussed in second slide is important is why we are classifying, because classifying on the basis, because we need treatment on the mild intermittent, mild persistent, moderate to severe, and severe persistent. We have 2 categories. Either it's intermittent, either it's persistent. Persistent is throughout the year on and off. Intermittent, it's like it's again means you are asymptomatic for a brief period of time, 1 to 2 months, and then again seems so intermittent. So on the basis of symptoms, you classify it's a mild category, it's a mild intermittent or mild persistence. So that's why it's important. If you have a mild intermittent, go with second generations antihistaminics only. mild, persistent means perennial throughout the year. Then the second position instance in what is I is inhaled steroids. NRTI is nicotine receptor antagonist like this, mast cell stabilizers and all this thing. Montelukast, corticosteroids. Moderate to severe. This, like if you are saying this is step up and this going on will start with a single dose, when we are adding again and again, if not responding, we are going to higher symptoms and adding drugs. It's not like if the patients come to you with mild symptoms, you just go with the fourth one. You start with saline irrigation, steroids, immunotherapy is not. It's not recommended because symptoms are very mild. You start with a single drug. If not responding, then step up. Then not responding, step up. And in case of refractory cases, we go with the immunotherapies. That's why classification is important. That's why different drugs are important. And when you follow up in your patients, if they're responding, you continue the treatment, and how long depend on the patient's symptoms. If not responding, step up the symptoms and all this. It's not like persons particularly. If patients, you classify the patient on the severe category and persistent category. It's not like you start with second generation antihistamines. It will not remove them. The patient will not get benefited. It's just like a mild. It's like you just started 10% of the treatment and you want to feel the patient's symptoms. He will not be symptoms because the category is severe one and the treatment part required is step 4 type of category, because we have to be able to educate them in nasal cell irrigation, inhaled steroids, nicotine receptors. If not responding, we go with slit and skit, like immunotherapy, sublingual and skit cutaneous policy. And severe areas, epilotomy nasal spray. So that's why it's important to allergic rhinitis. Start with the classification, step the treatment, classify, then give the treatment according to the category. If not responding, step up. Don't jump to the higher categories and don't start all the treatment at the part. That's why it's important. So this is all about, because allergic rhinitis itself is a very broad. It's like we can go with it 2-3 days and we can talk in months about allergic rhinitis. It's so much weight, but for your brief, what at your level at MBUMST level, fine, this up to this is fine. If you can able to elicit this one, this is very good for this. Okay. So what we are, this in brief just about what, because it's in like fancies, everybody prescribing taken metal steroids, but because there is limitations of particular type of age, what we are doing is in particular type of, because we have nailed the micros in terms of micrograms, not its milligrams. Just to make what we have steroids, systemic oral steroid, we will take in mgs. So what we have given directly, topical means directly particular area, but where the suppose inflammation is there. So that's why the doses are always in micrograms, because we don't need any systemic. So it's beneficial because it's about systemic toxicity of steroids also. So mometasone, fluticasone, furoate, and propionate. So what we can do is like it's always only mometasone we can able to start with more than 2 years. So next 4 and up to we can start above. Fluticasone, propionate, and furoate. It's in these accordingly like 100 mg microgram OD and OD in each nostrils. Like we have to spray. Taken puff on in particular type of protein. And for how long duration, but at least we have to continue, advise them for continue with the 3 months, because inflammation has not subsided in a day or two. You have to be patient and you have to particularly counseling, follow up them symptoms, responding and not responding again and again also according to you. So once you start with inhaled steroids, corticosteroids, you should wait for at least 3 months to achieve the symptom-free interval and what's the response of the patients. Monitoring, again, what we have told you, counseling the patient, follow up on after 1 month or after 2 weeks, whatever you feel comfortable, what the patient is feel comfortable. And if the patient is responding to you very well, if you are on a higher category, step down the treatment again and again broadly. Like you start with the corticosteroids, LRTI, then step if patient is symptom-free for 3 months, just step down the treatment. If not responding, step up the treatment. So that's why follow-up and monitoring is important. Because it's very common, some of us also are suffering from allergic rhinitis, allergic dermatitis. So there's a broad, it's not about pediatrics, it's same with adults also. So it's in broad classification, allergy is important. Allergy can be in pediatrics, it can be in adults. It's the same management, same line of approach, but throughout your career, throughout your life. So this is about allergic rhinitis. This is atopic dermatitis. Second one is, what is this? This is inflammatory conditions chronically relapsing. Means it's own again and again, it's coming up and it's going on. Non-contagious means not suffering from, if you are suffering from atopic dermatitis, none of your colleagues will get an atopic dermatitis because of you. And extremely pruritic means it's very itching and very pruritic skin. And roughly 20% of pediatric population and 30 to 40% of adults do have atopic dermatitis. these are the broad classifications, like how you classify these clinical features of atopic dermatitis, three major and minor criteria. So major criteria, at least three of you have, like out of four, at least three of them should have, then you are able to classify, and must on minor criteria you have at least three of out of these five. So important is major ones. We have pruritus, and there is a particular characteristic morphology and distributions. Relapsing, chronic, and cause. Relapsing means sometimes it may not flare up. You are symptoms free and no symptoms of allergic rhinitis, pruritus. Again, after 1 month, 2 months, 4 months, 5 months, it's again flare up. Then you have to take treatment for 1 to 2 months. Then it subsides again. So this is called chronic relapsing courses. And most important is what we have discussed in allergic rhinitis also, family history of particular sibling history of atopy. Atopy means allergy. Allergy can be too sensitive because of anything. So personal or family history of atopy, including these all are allergies: asthma, allergic rhinitis, atopic dermatitis, urticaria, and all these things. So family history positive, chronic or relapsing courses, particular type of morphology distributions of atopic dermatitis and pruritus. So these major criteria, at least three should be there to classify them as an atopic dermatitis. Minor features, three must have three of the following, like age of onset, xerosis, hyalin, keratosis, pallorosis. These all are like erectivities, and if you will to find out infections, because secondary infection with staphylococcus aureus and herpes simplex on already like on particular type of morphologic distribution, secondary infection from antibiotics, eczema, pityriasis alba, dermatographics, branching, peripheral inflammations, cataract. You are able to find out. If you know, you will be able to elicit and those symptoms: itching, sweating, foot dermatitis, conjunctivitis, tendon movements, and all this, because these are related with all other atopies also. So major criteria we should be able to know. Minor, if you are able to elicit, that is fine. So it's the same. It's also in clinical diagnosis. Scoring, same thing as scoring is why is important, because on the basis of in atopic dermatitis we have score. Score means SCOR is for score, AD is for atopic dermatitis. Scores on the basis of A, B, C. We have. I will let you know in brief in just a minute. If you have score less than 25, if you have like this is seen mild, then the score, if you have scores less than 25, that is mild atopic dermatitis. If you have scores between 25 to 50, you have moderate atopic dermatitis. If you have score at more than 50, you have severe dermatitis. That's why scoring system is important. Same with allergic rhinitis. Depending on the scores what you have, depending on the severity, mild, moderate, severe, you start the treatment accordingly. That is why in step 5, uncontrolled atopic dermatitis. That is why we classify, we score them, then on the basis of scoring, we classify them mild atopic dermatitis, moderate or severe, then start with the treatment part. So I'll go fast because time is restrained. But I'll give a brief about this how you go with a particular type of these things. So scoring on the basis of, first thing is rule of 9. Rule of 9 means like on what you have learned on the upper this face 4.5%, below is 4.5%, upper chest is 9, front of your hands is 9, back of your hand is 9, and this. So this is rule of 9. On the basis of rule of 9 means intensity. What on the basis of 0, 1, 2, 3 scores, on the basis of redness, swelling, aging, these are 1, 2, 3, 4. Redness, swelling, then comes oozing, then scratch, that identification, lichenifications, and dryness. On the basis of symptoms, you go with 0, 1, 2, 3, 4. Then you go with scoring. Subjective symptoms like itching and sleeplessness. So much of itching is there, not able to sleep. So on the basis, we start with 0 to 10. On the basis of itching, like on severity of itching, you will 0 to 10 for itching, and sleeplessness, able to sleep or not, 0 to 10. On the basis, then overall we combine them. A is what? A divided by 5. B we have intensity. B divided by. This is just brief for you. No elicit and read because, but we have to cover up these things. So on because how do you score? That's very important. A, B, C. Then we divides A divided by 5 plus 7, B divided by 2 plus C. So if we come out, then there's the score and systems. Then we come to a particular scores. If score is more than 50, I have shown you the slide. More than 50, it indicates severe. If score is less than 25, mild disease. Important because we start the treatment accordingly. Treatment important is non-pharm. We have two types of treatment. First thing, we educate and those things. If you need treatment themselves, so non-pharmacological treatment is important. What do you mean by non-pharmacological? Like cleansing, bathing, moisturizing, clothing. Cleansing means regular. In atopic dermatitis, it's important to go with the warm water. Always take bath with the warm water, 25 to 30 degrees centigrade, and for short duration, not like half an hour, 50 minutes. Always use pH cleansing, so free, neutral pH, that is fragrance-free and hypoallergics. Bleach baths. In case of circling, if you have like an atopic dermatitis and second infection of staph and staphyl on your skins, then we can take a bleach bath of sodium hypochlorite 0.005%. Moisturizers, we can have preservative-free and fragrance-free moisturizer we have to use. We can use warm water when we have all wet therapies. Clothing, it's like we don't use synthetic and woolen clothes. We use usually loose, light-weighted and soothing clothes like cotton. This is non-pharmacological. Eyeliner and avoiding same with allergic rhinitis, we have to avoid allergens, whatever they are triggering again and again to a particular skins. In skin, we have like chemical importance here. So, same with the allergen, pollen, how the should be avoided and what is encompassed. Tobacco smoke, avoidance, traffic exhaust, volatile organism exposure reductions. So, if you avoid, you will less flare of it for adults, allergic rhinitis, atopic dermatitis, whatever you have it. Dietary interventions, restrictions if somebody told you particular in your policy that's a particular patient suffering from after taking like banana, patient goes through like having stools and cramps and all those things. So if we diagnose clinically and confirm it with a specific IG or screen prick test, then we go for restriction of particular type of diet. Otherwise, we don't go just on the basis of symptoms. Like after taking banana, I used to feel uncomfortable. I goes to lose stools and all this. So just we don't avoid, we don't block these things. So if you have confirmatory evidence with you, then we only restrict diet on the basis. So non-pharmacological measures, what we have: cleansing, moisturizers, clothing, avoidance and dietary interventions. Pharmacological nations, topicals means at a particular local site. Here it is skin only. So topical corticosteroid TCS and topical calcineurin inhibitors. So gold standard is always topical steroids. So we have like if the patients can come to you on the basis of like acute flare, any particular type of particular disease preventing to acute flare up, and sometimes patients come to you. I do have allergic rhinitis, but right now allergic dermatitis right now I don't have, but in past I have taken, so I want to come to for management. I don't want that these symptoms flare up in future and I'm suffering from, so I want to take in treatment. So patient come to in both conditions, can be in acute state and for come to in for maintenance. So he or she don't want to flare up the dermatitis. The first one is reactive therapy. What we do here is we'll apply topical corticosteroid twice a day for at least for 2 weeks. And then we'll step up, we follow up after the patient what the response. And for maintenance therapy, instead of twice a day for 2 weeks, we go on a twice weekly applications because the patient is already relapsed. It's not an acute constitution. So twice a week, not twice a daily. So in 7 days, we have to apply 2 times a day, two times a week only. Topical cancer, if not responding to this topical steroid, we have calcineurin inhibitor, tacrolimus, pimecrolimus, and different concentration what we have in emulsions and in oils. So 0.1%, 0.008%, 0.1%, depending on whatever symptoms the patient is comfortable with. We can use. If not responding to TCS, we go with topical calcineurin inhibitors. Other measures, if refractory cases not responding to first two, we can have resistance cases of what we do. We go with, like in children, we go phototherapy for jaundice. So we can have treatment. We can go with ultraviolet therapies and this phototherapy in case of resistant atopic dermatitis. Antibiotics we can use if we have secondary infections overlying the atopic dermatitis, staph infection, staphylococcus. Oral corticosteroids we have very limited role, but if resistance cases not responding to all these parameters, we can give 0.5 mg per kg per day for one week to relieve acute. In case of acute flare, not responding to treatment, but not for a long treatment, only for 1 week. Newer modalities, what we have immunosuppressive therapies. Like first, what we have discussed, if not responding to, we can, if it is resistant case, refractory case, we can go for it like anti-cancer medicine, cyclosporine, immunomodulators, immunosuppressors, immunoprotectors. Biologics, we can use dupilumab, phosphodiesterase, phosphatidyls, Chinese kinase inhibitors, 2 different therapies. And specific immunotherapies, like if you are particular, if you want to find out a particular allergen is covering, you can desensitize them with particular therapies. So these are newer modalities. This is a broad step as many atopic dermatitis. If the patient has step 1 dry skin only, it's not atopic. Like you cannot avoid the treatments and use broadly, liberally use moisturizer and emulsions. And on the basis of score at 25, 25, 40 years, you will step up the use avoiding these triggers, simulation, moisturizers. Start with PCS therapies and models. If not responding, category 3. Start with tacrolimus and all this. Not responding, go with glucocorticoid, wet grapes, UV therapies, phototherapies. Step 4, not responding to first, second, third, immunosuppressive therapy, cyclosporin, methotrexate, mycophenol, mofetil. Not responding, go with the step up, biologics, dupilumab, and all this. So depending on the patients, what classify you categories in a particular start treatment and a particular type of mild, moderate, serious. Don't jump onto higher newer facilities and modalities like biologics and immunosuppressant in the mild cases. We don't go. We step up, we classify them, start with the lower one, not responding, then we step up the treatment again accordingly. Urticaria, on just brief slides about this. Urticaria, what we have, we can have anything with this. It's like every topic itself is in class, but what in your P1, whatever activities I have given, which you have to cover up allergic rhinitis, atopic dermatitis, urticaria, angioedema. So it's not possible just by going very fast, and it's not able to elicit anything. Urticaria, what do you mean by urticaria? It can be what we can have anything. We do have urticaria with wheals, angioedema, and both. Wheals has repeated. What's the difference between wheal and angioedema? Wheal occur in the superficial skin, whatever flare up, and this will flare up, circumscribed central swelling. Angioedema, same thing, edema, but it's in cutis. Lower dermis and subcutaneous plain and mucous membranes. So the basic difference is wheal usually occurred on a superficial skin, it's a flare up and wheal-like features and blob. We do find, but angioedema we have these edema same features, pruritus, burning sensation, but in dermis, lower dermis, subcutaneous plain and mucous membranes. Itching and burning sensation both we can have in both, but in angioedema we do feel sometimes very intense pain also. Wheal is resolved within 30 to 24 minutes. It usually takes more time, like less than 3 days, and slower than this. So basic differences between these things. This is important: acute urticaria and chronic urticaria. If urticaria is less than 6 weeks, this is classified as acute urticaria, and usually we can have any because of foods, because of medication steps, transfusion. Last one, first one. Chronic urticaria. Chronic urticaria, it's more than 6 weeks, means more than 1.5 weeks, but it's not because it's persistent. It's continuously throughout your 1.5 months. So it can be because of anything, because of physiological, idiopathic urticaria, neoplasm, because of anything. That can lead to chronic urticaria. What's your roll number? Last one. Okay. Acute urticaria, chronic urticaria, acute urticaria, because what is all we have discussed is type 1 IPG mediated. It can be IG mediated, can be because of foods, drugs, insects, latex, whatever. Acute urticaria can be because of non-IG mediated, like not immediately, but because of what? Like because of infections, dyes, opiates, and all those things. What in previous slide, what we have discussed, we can have urticaria because of like second slide, third one, we can have infections. We can have urticaria because of infections also. So next slide is about what different types of infection can we have. We can have bacterial, viral, parasitic, fungal, streptococcal, viral, hepatitis B, Coxsackie AB, parasitic Escherichia, stromalite, Escherichia, and all this, fungal, candida. So we can have, because of infections, we can have urticaria, non-IG mutated, different types of things. Chronic urticaria, usual definition is takes more than 6 weeks, and because of anything. It's two subcategories. Chronic spontaneous means it's because of without any triggers, it's going again and again, and without any known, it is second term is chronic idiopathic urticaria, and second category is inducible. Inducible means you know the particular trigger. If you are going to a particular sun, if you go out to sun and you feel, then you will start clearing in your symptoms, and then we can have different type of. So inducible is different categories. Chronic spontaneous idiopathic urticaria means, with idiopathic means there is no known cause, or spontaneous means again flare because of without you are not knowing, you are exposed to nothing, and again it's coming up again and again. So but in studies we do find this because of antibodies, because of anti-TP antibody, anti-thyroid antibodies, we can have anti-IgE because of different antibodies. We do have these types of symptoms. So if patients comes to you with an idiopathic urticaria without any known cause, you just investigate them with anti-TP antibody, anti-IgE and IgE receptors, and pathology test for particular serum sickness test. These inducible means what we can have inducible means you are able to elicit particular type of chronic urticaria of more than 6 months. We can have anti-area because of cold. If you expose a particular patient to a cold, we can elicit this one. How can you? So we keep an ice on your skin for 5 minutes, you will feel the angioedema or bleeds. Cholinergic urticaria, small punctate lesions along to particular nerves and all these things. How do you elicit? Hot showers, sweatings, but it usually resolves half an hour to 1 hour. Pressure induced, if you are particularly applying pressure to 4 to 6 hours, same type of symptoms you are doing. Solar urticaria, if you are going to sun, suddenly you start flaring up symptoms. It goes to you can symptoms of urticarias. It resolves by 1 to 3 hours. Aquagenic means because of water you can have urticarias, angioedemas, and not because of temperature. It can just because of the exposure of water you can have urticaria, that is called aquagenic urticaria. Dermatographism, you can most of us use your skin people. If you want to elicit within pores, or whatever you will elicit, you will find as a Russian marks we can evaluate, that is called dermatographism. It can be urticaria, it can be usual phenomenon because of other things. Diagnosis, same thing as with event and cause, making correct diagnosis, clinical history, avoidance of taking this chronic urticaria, fluids, even diary, labeled. Just educate them what causes you to cause flu-coughing symptoms. Suppose it's just educate them, make a diary, make an event that after starting these things and after eating these things, after going out to particular place, after exposure to sun, after exposure to exercise, I start flaring. I used to do flu symptoms. To educate them so they will able to learn you whenever they come to you again with follow-up, they will able to elicit you after these things, so we can able to classify them what type of urticarias they show. We can educate them about the triggers. Allergy skin attacks usually not for acute urticaria because it's because of intestinal it subside because it's an acute one. We don't need treatment for acute one. Symptomatically for chronic idiopathic urticaria, I have told you, usually we don't find any cause, but in studies we find out because of antibodies and same thickness, some of them we find positive, so we can go with the test for these things. Physical urticaria, we have discussed some aquagenic and all these things, so there is two physical and chronic urticaria. Treatment is just two more slides. Antihistamine, because same thing as these are antihistamics. What they do, they stable the mast cells, stabilize and all these things. Second generation, I told you why we are going second generation, because that's sedative older school going children and adolescents. Infant and toddlers, we can move with the first generation. These are different type of these antihistamines depending on the dose and all this. For children's strength, we can go with the hydroxyzine, diphenhydramine. For like adults in school and drugs, we can use cetrimine and all these things. In case if not resolving urticarias and converting it to angioedema and anaphylactic, we can go with an adrenaline also. This is in case of shock and all these things, not responding to particular treatment. Doses, what concentration do we have with the adrenaline? What proportions we have in vial? We have 1:1000 dilutions. And what we do is in RP, we dilute them into 1:2, we convert them 1 ml of 10, then 9 ml of MS, convert into 1:10,000 dilutions. So this is ready-made preparation, whatever we have within cash cart, whatever we have within. But usual preparation is this one. In standard preparations, you take 0.0 ml, 1 kg of these drugs. Suppose the baby is 4 kg, then divide this, multiply this 0.1 ml into 4. That's the drug. Either gives subcutaneously or intramuscularly. But in case of refractory cases or not responding angioedema. Oral steroids, not because of, we can do not respond these because in case of severe categories and severe anaphylaxis is there because of urticaria, we can give a short course of prednisone for 3 to 5 days, doses into 20 per kg per day. Treatment of chronic, this last slide, same thing because it's more than 6 weeks, so first we start with secondary for 2 to 4 weeks. Then we ask the patients to come after 2 to 4 weeks, we follow what? If the symptoms response, we will follow the responses to symptoms. They are tolerating well, continue with the symptoms, step down, not responding. Although we have only 2 categories, either responding, they are treating well, they are symptoms free, or they are not responding. Treating well, continue the step down, slowly taper down. Not responding, increase the dose of antihistaminics. What we have discussed here is, these are the standard dose according to per kg. But what we have here, what we are suggesting you, up to 4 times the normal dose. What we are doing, to go with the 4th into 4. So start with the standard dose on the first generation. After 2 to 4 weeks, ask them not responding, multiply your dose by 4. Give them 4th time of your standard dose. Again call them after 2 to 4 weeks, not responding, that is well, slowly taper down, step down, not responding, add biologics, only one inhibitors, In not responding, then consider these cyclosporin, immunosuppressant and all these things. In symptoms, like we can use steroids where we have discussed, or symptoms and lymph conjunctivitis. That's all. So it's already in itself is a very big topic. So everything is big topic. Allergic rhinitis atopic. It's very difficult to cover up all these things. So I'll just give you a brief size. What's the guidelines or different guidelines that we have, and it's important what treatment. So you can be able to visit in exams so it can be. Thank you. If any queries, you can ask me anytime later on.